Good morning. So you do know that you're the first people in this building, right? Yeah, this is really exciting. I said it even smells new. I moved into a new home, actually. You know, I moved to Washington, D.C., and let's just say I lived in a 700-square-foot apartment, which is a little bit bigger than the hotel room I was in last night, with my husband for the last year and a half, and no one can do too much in 700 square foot that the other person doesn't know about. So I'm really happy to be in a new home, and it has the same kind of smell, so this is like really exciting for me to be here. I think I want to start by saying, referencing this Chinese proverb that you probably heard, may you live in interesting times. This is just such a wonderful time in the history of healthcare. The opportunities that we have with the technology and the infrastructure that we're really beginning to build, and this idea that we're taking the same sorts of technological innovation that we have in other aspects of our lives and sort of finally bringing them forward into healthcare is just extremely exciting. The other reason I find it exciting is we got this infusion of money right through high tech in 2009, and over the last 3 to 4 years, depending on the program, we've been able to spur a lot of activity in this space. But now, particularly at the Office of the National Coordinator, we're kind of at this pivot time where some of the grants are starting to wind down and the federal funding is winding down. And what's exciting about that is to see the additional innovation that's starting to take place and the market kind of taking over. And I think this Global Center for Health is a good example of that, the bringing together, if you will, of different kinds of providers and different kinds of vendors in one space where you could potentially look at the health IT systems along with the smart beds and the smart pumps and maybe come to a conference that you hear about those things. So anyway, I just find this extremely exciting, and I have this great sense of hope for where we're going to be going in the future. I just feel like this is maybe sort of the end of the beginning, and we've got the middle and we've got the end, and we've got a lot more work to do, but again, very exciting and very interesting times. So for my presentation, I'm going to run through 3 kind of areas, touch briefly on where we're standing yesterday, if you will, the statistics on how we're doing with meaningful use, and then look at today. You know, what are really our key priorities? And I'm going to touch on health information exchange and patient engagement. Both of those have full sessions later in the day, and so I'm not going to go into depth, but just kind of to set the stage for both the Health Information Exchange panel and Danny Sand's presentation on patient engagement at the end of the day. And then third, look at tomorrow. What are our biggest challenges as we think about where we stand here today and where we need to go into the future? And again, Dr. Miles already sort of set the stage for that in terms of thinking about the triple aim. Remembering always that health IT is not an end unto itself. I know some of the times it feels like that. How many of you are implementers? Like actually doing implementation? Okay. How many work in IT? And you can raise your hand more than once, just trying to get a feel. Nurses? Doctors? Okay, so a good chunk. And so everybody is obviously connected with this electronic health record thing. So you get to the end of an implementation, and you're like, whoa, that was pretty hard. Yeah, this order set stuff, or this CPOE stuff, or this e-prescribing stuff is really kind of tough. And so you sort of want to take a break, right? You kind of want to say, well, I'm done, but not really. And that's the important part to think about here, that this is, again, the means to the end. Getting it in is, again, sort of step 1. And what we really have to do is take that tool now and maximally utilize it to transform healthcare, both the way we provide the care clinically and then, of course, the way we pay for care, too. And so integrating this in with other programs that are going on, depending on what venue you're in, whether you're in education or whether you're a provider, thinking about how you're going to now use these tools that are in to the best way to actually change what we're doing. At ONC, we've been talking about the habits of healthcare, changing the habits of healthcare, because you know we really are ingrained in how we've done things, and to change that is not simple. And It's often been referred to as a culture change, right? In fact, somebody said this a couple of weeks ago, and I thought it was kind of funny. You know, the culture eats strategy for lunch. Has everybody heard that? Well, the way they said it was culture eats strategy for lunch, and health IT is a condiment. And I thought, that's intriguing. So again, we'll spend a bit of time talking about that. Now, I want to identify that if we're going to be successful in what we have to get done today, and we're going to be successful in what we need to do tomorrow, workforce is really going to be key. And of course, that's the theme of the conference. How do we change not just how we're training new people as they come into the industry? And when I say that, I'm talking about nurse training, doctor training, radiation therapy training, respiratory therapy training, pharmacy training. How are we changing those kind of workers as they enter in? How are we training our specialists? So we've got the nurse that wants to be a nursing informatician. How do we train that person? But even bigger than that, for me, is the existing incumbent workers. How do we get this culture change if we don't focus on the people who are out there really doing the work? And so I'm really going to wrap up with setting the stage for that and outlining what I see as some of the challenges as we really think about changing these habits of healthcare. So meaningful use has been an unbelievable journey over the last few years since the HITECH Act. So if we look at where we stand today for eligible professionals that have been registered and paid, you can see the graphic here. The good news for us at ONC is we had strategic goals for 2012 and 2013, and you can see we sort of blew those away, which was wonderful. You probably also saw a bunch of press over the last few weeks. In fact, Kathleen Sebelius, the Secretary for Health and Human Services, actually put out a press release talking about we finally passed the 50% mark. So this is a graphic showing eligible professionals that have been registered and paid, either through the Medicare program, which is the Meaningful Use program, or the Medicaid program, which is where we pay for adopt, implement, or upgrade, that AIU. Okay, so we're looking at 56%, a denominator of about 521,000. 56% have been paid, and then we have another good chunk up to 75% who are actually registered. Now, if we look at how that relates to the nation and then bring it home to Ohio, yes, you guys are doing great and you are above the national norm. So the blue shows the national norm and the red actually shows where Ohio is. And trust me on this one, I go to a lot of different states. The red is not always above the blue. And so you guys are actually doing quite good in this professional space, above the average. If we look at hospitals, hospitals have been doing a lot better. Here we're looking at 77% of the hospitals that have been paid through Medicare or Medicaid. And by the way, these statistics are through the end of April. Again, we've blown away the goals, and we have another percentage up to 87% that are at least registered for the program. Focus here over the last year in particular has been around critical access in rural hospitals. They've always lagged in the health IT adoption, but we started to see about a year ago a widening of the gap in the lag, and so we've really been focusing through the Office of the National Coordinator and our regional extension centers on that particular space. So when I look at that 13% that's left, a fair number of that is in our rural and critical access. And what we can't do, obviously, I think this is, I'm just going to say it, everybody would agree with this, we cannot turn this into a program of the haves and have-nots. So we absolutely have to focus on them during this home stretch here and make sure that we bring them up with everybody else. If we look at hospitals in Ohio, blue again is the national average, red is Ohio, and you guys are absolutely doing above the average again here, so that's really exciting. And last statistic I'll show is the graphic with month-over-month payments, again, Medicare or Medicaid payments. We have put out, through the program, $14.6 billion. That's out of a total of approximately $20 billion. And so, when you look at that, we're actually doing quite well as we go into this really last year of the program. Well, the programs for the grants supporting the program, the monies actually keep going. However, we do go into the penalty period starting next year as well. And so we're hoping that we can keep those percentages up so the minimal number go into the penalty period. Okay, so then if we start talking about these key priorities in stage 2, I already mentioned health information exchange, or using health information exchange to create a patient-centric health care and health care record. Now, I'll emphasize again, this relates to the habits that we have. This is how we provide care. This is our culture. Today, we do not think in a global way. We don't think across venues. We typically don't practice that way. Now, some of that has started to change with our integrated delivery networks, where maybe within the same system, they have ambulatory, they have home care, they have acute care, and there is some continuity of care between those. But if you think of the really classic health care and the way we provide it, our patients think nothing, and this happened to me within the last couple of years. Our patients think nothing of going down a hallway into one door, going and seeing their primary care practitioner, giving their demographics and their insurance information, as well as clinical information related to their allergies and all those kinds of things, being seen, walking out of that door, walking down the hallway, walking in another door to have a radiology exam, and giving all that information over again. And maybe even going to a third doorway to go to the pharmacy and giving that information yet again. This is how we all grew up. So none of us really have ever expected it to be different. And quite frankly, our patients are just beginning to identify that maybe this should work like your Starbucks card. You know, like maybe if I go to a Starbucks in Rome, they actually can debit the card when they buy the coffee, or like your ATM card, right? And so that demand is starting to creep up. I know I myself executed that. I felt quite good about myself. I went actually to the same place to get glasses, and they wanted me to fill out the form on the clipboard, right? And I said, no, I've been here before. You have my information. And they said, oh no, you have to redo it every time. I said, why don't you take the old stuff, print it out, I'll update it with initials, redate it, and I'll give it back to you. Oh no, that's not how we function. I said, well, then you don't have my business. And I walked out. And then, of course, I was panicked because I had to get my prescription. You know? And it's like, did I really do that? But again, that demand is just beginning. You know, today, patients really differentiate quality on what? The cleanliness of the lobby, the way they interact with the housekeeping person. You know, they really don't think about this integration, and they really don't think about quality typically. But again, I think we're going to see that change, and I think we're at that sort of pivot point where people are starting to realize, well, maybe I should demand in healthcare the same thing I demand everywhere else. And then patient engagement, that feeds right in as we think about the interoperability and then engaging the patient. So let me talk briefly about those things. So health information exchange, we've been doing actually quite well in a couple of areas. This particular example is e-prescribing. Center for Medicaid and Medicaid Services have had incentives related to e-prescribing for quite a number of years, which is why this particular metric actually looks quite good. If you look at the left, and the yellow is 0 to 19%, you can see there's almost nothing in 2008. And when you fast forward to the last, and this is SureScripts data, when you fast forward to the June of 2012, you see quite a good amount of penetration. Some of the dark green is 80 to 100%, and that slightly lighter green is the 60 to 79%. So again, doing really well. The overall statistic in the country through the SureScripts data is that 92% of the pharmacies are actually enabled to receive electronic prescriptions. However, only about 50% of the prescriptions are actually sent electronically. And we continue, of course, to have some states that think it's actually safer to call in a narcotic prescription or to fax a narcotic prescription than it is to send it electronically. And some of those rules and laws are actually starting to change. That's typically a state-based issue. So we've got some things going on here in terms of why this isn't going even better, but again, pretty good. If you look at the curve, just looking at our state-designated health information exchanges and how we're doing with that from quarter over quarter, starting with quarter 2, 2012, and looking into quarter 4. We don't have our quarter 1, 2013 data yet. You can see that hockey stick is just beginning. And these are the two different types of exchange. On the left-hand side, you see the graphic for the directed exchange. and on the right-hand side, the query-based exchange. In addition to that, I've got a couple of bullets related to vendor-based exchange. So there's some vendors that have set up the capability of interacting with other people of the same ilk and making it easier within the same vendor product to actually exchange. And then we've got some bright spots in terms of areas of the country where this has actually moved quite well. But again, broad implementation of health information exchange is not occurring, and that's part of our challenge as we head into stage 2. So in fact, at stage 2, and many of you probably know that the vendor products for stage 2 are just beginning to hit the market. We've got, I think the last count, 88 products that have been certified to stage 2, and a small number of those, like a single-digit number, are actually complete ambulatory products or complete hospital products. So we've got a ways to go yet this summer in the certification, but the initial time that you can start to think about a testing for stage 2 meaningful use is October 1st of this year. I don't think we're going to have a lineup of organizations, because if you think of it, they'd have to install the stage 2 software and then get it all up and running and know that their metrics are good enough. So my sense is that the measurements mostly are going to be starting in January 1st or April 1st of next year. And you may recall the measurements have to be by quarter in stage 2. So it isn't a rolling 90 days, it's by quarter. But here's just an example of some of the interoperability criteria that are at stage 2, where we're having actually quite a step up of what's expected. And the idea here is to really push the marketplace. We actually thought, we as an industry, not we as ONC, but we as an industry, I think, actually thought that health exchange would take off quicker and faster. And as I was pointing out earlier, I think so many people were focused heads down on getting that electronic health record in and getting CPOE up and running and getting documentation up and running and maybe doing even some non-stage 1 stuff like barcoded medication administration or those kinds of things, that they were really focused on getting the products in, that kind of looking up and thinking about exchange wasn't really occurring. And so trying to push that market at stage 2, the meaningful use work group really wanted to put a fair number of things in. And so here we've got e-prescribing for inpatient discharges as well, summary of care exchanges or transition of care summary exchanges, not only the ability to create and transmit from, but receive and incorporate back in. Lab tests from inpatient to ambulatory, public health reporting, quite a number of public health, again, quite a step up. Immunization registries, that's always one of my favorites. So I came from Wisconsin, as Norma mentioned in my introduction, and I just thought everybody was like Wisconsin. We have had an immunization registry, oh my goodness, like for, I don't know, I should look back, but I think it's been like 15, 18 years, something like that. Now, access to that was only clinicians. Even in Wisconsin, we don't have access by patients. So how do I maintain the immunization registry for my now 27 and 30-year-old is on the little card that I initially wrote the information when they were born in 1982 and 1985. And when I moved, remember I mentioned I just moved, I was afraid I was going to lose the card. And the card, for all the years that they've been around, has been in my telephone directory. Now, as many of you know, we don't use telephone directories anymore, right? We have all our phone numbers in our phone. I hung on to my telephone directory because that was the location of my children's personal health record with their immunization registries. So this is the kind of funny stuff that we do, and could I take that and scan it and make it more electronic? Of course. The funny thing is my daughter's actually moving to Singapore for a couple of years. She's a teacher, and she actually called me while I was in DC and said, I need my immunizations, and I was actually able to put my finger right on where those puppies were. 3 states in our nation, only 3, allow patient access to immunization records. Go figure. Not all of our states. There's still like a handful of states that don't even have provider access to immunization registries. So this is the kind of stuff we just actually have to just push forward. Thinking about the patient again, the ability to view, download, and transmit. So you probably recall at stage 1, there was just this little itty-bitty thing that we had to do, a test of the ability to download a record and give it to a patient. It just had to be a test. So what did we all do when we had tested at stage 1? We tested it. What we didn't do was roll out a program. What we didn't do was think about, oh, wow, I think maybe this should be a hint of something to come. I think maybe this is the right thing to do. Some of us, and I include Aurora Healthcare in that, when we tested for stage 1, it was a check of a box. Did you do the test? Yes. Now, we had the capability, right? So what could we have done? We could have given the nurses buttons that say, you can have a copy of your electronic health record. Ask me about it, right? Or I have a personal health record. Do you? Ask me about it. So we didn't do those kind of campaigns yet. At stage 2, of course, a percentage is now involved. It's not just a test. You have to have 10% of your patients who are actually doing it. So the marketing campaign needs to begin. And then last but not least, the ability to create an export summary of patient data. And the idea there is to increase the data portability so that if a patient moves or if a organization wants to move from one electronic health record to another, that there's some basic capability, and that's all this is very basic, but a basic capability of being able to transport the data into a new electronic health record. So in terms of the interoperability, I wanted to draw attention to some training modules that we have posted fairly recently within the last 3 months on healthit.gov. There's 5 different modules. The first one is Interoperability Basics. Again, these are self-paced learning modules that are available to anybody and everybody, but the audience for this is really implementers. So it's the people who are working at a provider organization doing implementation. Again, self-paced, but it seems to take most people about an hour, 70 minutes or so. It goes into depth about what you need to know about what your vendor is providing and what accountabilities you have. Because when you start thinking about data exchange, it's no longer just what the vendor provides, because one of the criteria of the exchange of a transition to care document is that you have to exchange between vendors. Okay, and so the idea is, again, it would be a whatever product to whatever product, but it can't be within the same product. And there are 5 different modules, one for each of the interoperability criteria at stage 2. So patient engagement back in the day. The AMA Code of Ethics in 1847 said the obedience of a patient to the prescriptions of his physician should be prompt and implicit. The patient should never permit his own crude opinions as to their fitness to influence his attention to them. Thank goodness it isn't like this anymore. However, we all grew up in this sort of culture thing about this is how things worked. And I'll just point out my mother is a case example, so she's still in Milwaukee, I'm in Washington, D.C. She calls me up 6 months or so ago and she says, oh yeah, I have to have a colonoscopy. She's 88. I said, really? Why? And she said, well, I got a card in the mail and the doctor thinks I should have one. And I said, Mom, if you had a colonoscopy and they found cancer, would you have surgery? And she said, oh my God, no. And I said, well, would you have chemotherapy? No. And I said, well, then why are you having the colonoscopy? And it's kind of like this idea that, if the doctor says it, I need to do it. You don't question, you wouldn't have a second opinion. And many, 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 it's not just her, many of us have grown up that way. I know I wanted her, she has a lot of pain because of diabetic neuropathy and arthritis, and I wanted her to go see a nurse practitioner. And oh no, it's a doctor or nothing. The only thing that counts is when you see the doctor. And I'm like, but these are nurse practitioners. I finally got her to go. But it's one of those interesting things. And by the way, my explanation about the colonoscopy worked well until about a month later she got the mammography card. And, again, we just all sort of grew up with this sort of siloed kind of care and this sort of one-way transmission, that this idea of changing that to some of the things that we're talking about now. Interestingly, Leonard Kish, who's an informatician working on HL7, I took this right off of his website, or the HL7 website where the quote was originally initiated back in 2012. He kind of coined this phrase, patient engagement is going to be the blockbuster drug of the next century. Actually saying that this could be a bigger breakthrough than a really important new drug therapy. So kind of exciting. And healthcare informatics, they do this top 10 tech trend list every year. They, in February of this year, identified patient engagement as one of the top 10 tech trends. So as I pointed out earlier, we're starting to get some momentum around this. Now we need to work it into our programs, into our education, into the way we deliver care. So again, at stage 2, we've got some stuff where we're sort of stepping it up, things like reminders for preventive care, educational resources identified and provided, online access to personal health information, visit summaries, the fact of allowing patients to send secure messages, and then last but not least, this view, download, and transmit that I already talked about. And so again, the purpose of that view, download, and transmit is that they can look, they can download it. If it was my mother, if she could execute those first 2, she could then send it to me. Or it could be somebody who wants to download it and give it to another practitioner. It could be somebody who wants to download it and put it into a personal health record. But this idea of packaging it up and creating some transportability, there's been a fair number of people that are starting to say, maybe the patients should be the hub of the universe. And since it's going to take a while for all the providers and all the organizations to start connecting up, maybe what should happen is every time you have a healthcare encounter, you make sure you get a copy of your information, and then you as the patient become the integrator through your personal health record. And we're referring to that as consumer-mediated exchange, but it's got some potential, maybe not for the general populace, but for some select folks. So again, kind of an intriguing idea. So going back now to this overall theme and kind of heading into the home stretch here of my presentation, you probably recall, if you were following the high-tech work, this particular graphic, which showed stage 1, stage 2, stage 3 criteria, starting from this get the electronic health record in through data capture and sharing, and then moving into the more advanced clinical processes where we're actually looking at health data exchange, we're looking at clinical decision support and doing some additional things with our systems, looking at how do we incorporate best practice, and then moving into improved outcomes at stage 3, and really being able to show at stage 3 how we're changing healthcare, changing those habits as compared to just kind of maturing what we did at stage 1. So I think, again, we're at the crux. You could kind of say stage 2, we're not all implemented, but at least creating the criteria is sort of behind us. So now we're going this forward-facing, who do we want to be and what do we actually want to do at stage 3? And if we wanted to focus it all on outcomes and actually changing the way we provide care. So what we're aiming toward, again, and I chose to use the National Quality Strategy. I could have put up a very similar graphic for the 3-part aim, right? Because it's the same components. So better health for the population, better care for individuals, and lower costs through improvement. So better health care, and lower cost. That's what we're aiming toward. That's why we're implementing health IT. That's what our workers are destined to have to look at as they take the systems that we've implemented and actually optimize their use and think about how we actually use those tools to change those habits of healthcare. And so meaningful use is a building block, right? We don't want it to just be check marks on a form. We want it to be integrated into strategy of an organization. So when we think about stage 1 meaningful use, it just had a couple of things. And stage 2, we added on a few more. But if we get into things like we're going to be talking about today, patient-centered medical home, health communities, the 3-part aim, we have to add in some things that are different than what we've already done. And if we go yet to the next level of whatever stage 3 is with quality, and where our end game is toward thinking about accountable care, managing the health of populations, looking at individual care, but making sure that that individual care is within the context of a community. And it's not just population health, right? It's making sure that wherever that patient is encountered or encounters healthcare within a community, that everybody knows everything about them. One more quick story on my mother. I was telling this story last night at dinner. So we were on the phone again, and she said, they're doing something new for diabetes now. And I said, really? What are they doing for diabetes? And she said, they're checking your feet. And I'm on the phone, like I said again last night. I was happy because they had done it, but I was horrified that she never noticed before. I mean, she's been a diabetic for 30 years, right? And so I'm thinking, oh my God. But some of these kinds of practices are now being embedded and hardwired into our systems. So the reason she noticed is that she was with the nurse practitioner in the pain clinic, and the nurse looked at her feet for the first time, I guess. But interestingly, everybody now that encounters my mom thinking about those same outcomes, and everybody being vested in making sure her high blood pressure, her diabetes, her arthritis are all under control. And it's not just the primary care physician that worries about that, right? So that's what we're focused on, is thinking about how we're actually going to use these tools to have that coordinated care. And when you have the data available everywhere, then you've got that capability of providing that kind of hardwired care that I was talking about. So again, we're really moving from just utilizing the technology to actually transforming the way we provide healthcare. So my last slide here, this changing the habits idea. What are we going to be able to do as we think about workforce and how we need to pivot the training and education that we actually do, whether those are those new programs again, or whether those are the incumbent workers. We need to think about that, focusing on people and process. So again, many of you are thinking about and doing health IT implementations. You've certainly heard the term, it's people, process, and technology, right? And people often say 80% of the work is about the people and process, and only 20% is about the technology. And I don't know if your personal experience has been that, but that was certainly mine. You know, changing the minds and getting the redesigning going on and actually using those tools to the max of their capability is often the really hard part. So really thinking about how we're going to be able to change that ability of people to look at what they do and re-engineer and redesign the workflow. Again, I used to think that systems were supposed to mimic our existing processes. Nothing could be farther from the truth, right? We want to maximally utilize the good processes that we have and maximally utilize the tools to change the processes that we have to actually make a difference. And use those tools so that 2 + 2 = 5, right? And so thinking about that and how you are going to train people to be able to think that way is part of the challenge. Focusing on the value of the investment. So again, this isn't about taking a meaningful use checklist and going, got that, got that, got that, but rather, somebody's making me do this and it's listed as a criteria. I'm doing this for a reason, and part of the reason is to think about how I integrate this into the care that I provide. So advanced directives is my example here. You could say that advanced directives is, the criteria at stage 1 basically says you have to know whether the person has one or not. And so an admitting clerk could do that. They could say, do you have an advanced directive? The person says yes or no. You document, you have met the letter of the law. But what do you really want to do with advanced directives? And what have we seen through the work that went on at Gunderson in La Crosse, Wisconsin, and how they've moved their whole population because they're having the conversation about end of life and they're making sure that everybody has advanced directives, is really incorporating not do you have it or don't you have it, but if you don't have it, you should, and if you do, give me a copy and let's talk through it. But making sure that we're using that to do what we know is the right way to change those habits. And again, looking in the areas of clinical quality, cost, and productivity. And last but not least, kind of wrapping this whole thing up, is really focusing on optimization. Getting it in, getting people familiar with how to use the electronic health record is step 1, and then the tips and the tricks and the, do you turn the screen when you're in the exam room so the patient can see it? Do you open up your notes to the community, or not to the community, to the individual, if you're in a situation where you can certainly feel comfortable sharing that information, whether it's an acute care setting or an ambulatory setting? So how do we actually start to think about doing those kinds of things, and how do we get everybody thinking about how important that actually is? Okay, so with that, I'm going to wrap up and just say thank you so much. I hope I set the tone for the day, and we're going to be diving deep into some of these topics later in the day, and I thank you so much for your attention.